All right, welcome back. Today we are doing a deep dive into a bacterium that is really forcing us to rethink some old assumptions in clinical microbiology, Enterococcus gallinarum.
For years, we've kind of dismissed this one as a minor player. But the big question now is it really just another harmless bug in the gut? Or could it actually be a hidden trigger for systemic autoimmunity? Let's get into it.
So all the information we're covering today comes from a Gemini deep search, and it really maps out this huge shift in how we're starting to understand this organism. If you want to check out the primary literature for yourself, all the sources are linked right in the notebook document. Okay, so here's our game plan. We'll start with how we're reevaluating it, then get into Lab ID and its really unique resistance profile. After that, we'll explore that wild link to autoimmunity, and then wrap up with treatment and, of course, infection control. First up, a bacterium reevaluated. This is all about the move from seeing it as a simple gut commensal to something way more complex, a pathobiont. So let's start with the basics. Taxonomically, Enterococcus gallinarum is a gram-positive coccus, part of the phylum Bacillota. And historically, we just saw it as this low-virulence bug hanging out in the gut, not causing much trouble. But that simple view is pretty much obsolete now. Which, of course, brings us to the lab. How do we actually identify this thing? And let me tell you, getting the differentiation right isn't just an academic exercise. It is absolutely essential for patient care. So, on the bench, it looks a lot like a classic Enterococcus, right? You've got your gram-positive cocci, it's a facultative anaerobe growing on blood agar, it's bile escalin positive, and it can handle 6.5% salt. No surprises there. The real challenge is telling it apart from its more famous relatives. So, how do we tease it apart from the big players like Enterococcus faecalis and Enterococcus faecium? Well, it comes down to a few key tests. The first big giveaway is motility. Enterococcus gallinarum is motile, which immediately separates it from the usually non-motile faecalis and faecium. Then you look at MGP fermentation. It's positive, which again helps you draw that line. So you can think of it as a simple little pathway. First, you check for motility. If it's motile, you can pretty much rule out E. faecalis and E. faecium. Second, you confirm with an MGP fermentation test. And third, to separate it from its other motile cousin, Enterococcus cassulaflavus, you just look for pigment. E. cassulaflavus makes that distinct yellow pigment, and E. gallinarum doesn't. Simple as that. And that brings us to what is probably its most defining feature. Let's talk about its intrinsic resistance profile. I like to think of this as a tale of two VanS. You see, Enterococcus gallinarum have the VanC1 gene. And this is so important, it's not some gene it picked up on a plasmid. It's chromosomally encoded. It's just part of who this bacterium is. It works by changing the building blocks of its cell wall, which means vancomycin just can't bind as well, giving it this low-level resistance. Now, this contrast right here is the critical takeaway for anyone in the lab or in infection control. VanC is intrinsic, it's on the chromosome, and it's non-transferable. It only causes low-level resistance, and crucially, the bug is still susceptible to teicoplanin. This is a world away from the dangerous acquired plasmid-mediated VanA and VanB genes that cause high-level resistance and can jump to other bacteria. Telling these two apart is a massive responsibility for the microlab. Okay, now for the major plot twist in this story. Let's move from just infection to autoimmunity. This is where we have to get familiar with the pathobiont concept. So it can cause the usual hospital-acquired infections. We're talking bacteremia, endocarditis, UTIs. But the really groundbreaking idea here is its role as a pathobiont. Basically, it's a resident gut microbe that, in the right person, under the right conditions, can actually drive disease. So how does this even happen? Well, research has laid out a pretty clear pathway. First, something has to compromise the gut barrier, letting the bacteria escape. Second, these viable bacteria then translocate, traveling to places like the liver and spleen. Third, their presence there kicks the immune system into gear, specifically triggering pathogenic Th17 cells. And finally, this immune activation causes the body to lose self-tolerance, leading to autoantibodies and driving diseases like lupus. This completely new understanding makes treatment, complicated. So let's talk about treatment and management. And honestly, it feels a bit like navigating a guideline-free zone. Because there aren't any specific guidelines just for Enterococcus gallinarum, we often have to extrapolate from what we know about other enterococci. For instance, the Dutch SWAB guidelines for ampicillin-susceptible enterococcal endocarditis now lean towards a dual beta-lactam therapy. That's high-dose amoxicillin plus ceftriaxone for a full 6 weeks. It's a way to get the job done while avoiding nasty aminoglycoside toxicity.
But for bacteremia, the data tells a more complicated story. There's this critical dilemma where what we see in the lab, in vitro susceptibility, doesn't always mean it's going to work in the patient. Even if a bug looks susceptible to ampicillin, some data suggests that treatment with linezolid or high-dose streptomycin actually leads to lower rates of treatment failure. This is a huge deal. It means for really serious bloodstream infections, just looking at the MIC might not be enough.
And things get even tougher in the pediatric world, especially with CNS infections. There was a really well-documented case of neonatal meningitis that failed standard therapy but was eventually cured with linezolid. This case really hammers home 2 points. 1, you need an agent that can actually get into the central nervous system, and 2, you need a prolonged course. We're talking 3 weeks or more to make sure you don't get a relapse.
Okay, finally, let's talk prevention. Section 6, Infection Prevention and Control. And the keyword here is nuanced.
The core strategies are exactly what you'd expect for any VRE. Hand hygiene is king, you use contact precautions, you clean the environment, and you practice good antimicrobial stewardship. But the key nuance is all about the genetics we talked about. Because the VanC gene is chromosomal and can't be transferred, Enterococcus gallinarum just doesn't pose the same epidemiological risk as the VanA or VanB enterococci. It's not going to pass that resistance gene to something like Staph aureus, and that is vital information for any infection control team doing a risk assessment. Which leaves us with a really fascinating question to think about. As medicine gets more and more into targeting the microbiome to treat diseases, could we one day see therapies designed to specifically eradicate or suppress Enterococcus gallinarum as a way to treat certain autoimmune conditions? It's a pretty wild thought. And that's our look at Enterococcus gallinarum. For more explainers like this, right from the front lines of clinical micro, make sure you subscribe to the channel. We really value your expertise and your insights, so please share your feedback and your thoughts in the comments below. Thanks for watching.